Morning, Nate.
Morning, how are you?
Francis. Good, how are you? Morning, Francis.
Good, thank you.
Good morning.
Morning.
Morning, Sid.
Morning.
Brennan let me know he was not going to be here, and he's so far the only one that let me know that.
Okay. Got myself, Francis, and Rob is official, right? He's got a street cred.
He does indeed.
I think I'm official.
Nice. Officially welcome, Rob. Thank you for joining.
Yeah, thanks. I'm excited to be a part of this.
We'll see if that holds up for a while, Rob.
Is that how it goes, Francis?
Sid, it looks like of a Brennan hand being out. Denise, Vetch, or Dr. Lairfield. Is
Correct.
Carl's here, yeah. So we've got 4.
And Dave.
I think 4 gets us a quorum, does not?
Are we not 8 at this point?
That's
Correct.
a good point, Francis, yeah. The new guy, Rob, he's got our math all wonky now. Got to get to 5. But he's here, so that's all that matters.
Sorry, Jimmy. I just serve as the disruptor now. It's disruptor.
Now Dr. Lairfield's in. Perfect. So we got 1, 2, 3, 4, 5, 6. We got a majority. All right, so we've got 6 of the council members present. Let's go ahead and get the meeting started. We are the April 6, 2026 Senior EMS Advisory Council meeting. We have an agenda, so call the meeting to order. Looking for a motion to review and approve the minutes for March 2nd.
I'll make my first motion.
Nice. Can
I'll
I get a
second.
second?
I'll
And I
second.
have a second. Is there any, looks like Denise is coming in as well. Any discussion to the meeting minutes from March 2nd? Hearing no discussion, then we will do a roll call vote. I will start with Rob, yay or nay?
Yay.
Carl, yay or nay?
Yay.
Dr. Lehrfield, yay or nay?
Yay.
Francis, yay or nay?
Yay.
I am a yay. And Denise,
Yay.
you're perfect. All right. My motion approves. Now we will move to old business, review of council vacancies and applicants.
I checked this morning. So far, we have no new applicants.
Okay. So just,
And
yeah,
if
we're ready.
anyone has any idea on how to contact doctors that could fill the role, please let me know. I'd be happy to reach out.
We have a new doc who just got done this fellowship. I might reach out to him, see if he has any curiosity. Is there any specific parameters, Sid, that he or she would need to have?
They have to be an EMS physician.
Oh, I'm gonna put my hooks into him. Perfect. Okay. Thank
Yeah,
you.
and
All right, we will.
Sid? If I could, Chief Samaria, Sid,
Yeah.
which are the two positions that are open currently?
We have the one for the EMS position and then one for a backwards contractor, which is very difficult because we only have one of those at this time in Oregon, which is Mid-Valley Ambulance that contracts with Eugene. And
Got
from
it.
a corporate level, they're not interested in participating, was the last that I got 2 months ago.
Excellent. Thank you for the update.
All right, let's move to new business. We've got grant awardee reports. Turn it over to you, Sid. Let you drive.
Okay, first up is Albany. Ray, would you like to give an update, please?
Sure. So obviously, oh, darn computer here. So we had 21 requests for the lift assist. 11 of those were not transported. 10 of them were. None of them needed referred to an alternative care. And then same with the 11 patients were not injured. They didn't receive any medical care and just needed help up. So I mean, I see a decrease since we've started the program, and looking at March's numbers, I haven't submitted that yet, but it's going to be the same. So, starting to see a decrease in the number of times that we, as a department, are going out to do lift assist at the care facilities. So it tells me that they're at least using the devices. But the biggest, and I think I have it down here on the bottom, the biggest thing we'll see is just compliancy to get them to document. That's the hardest thing that we're coming up with at this point. And on this month in particular, we had 8 patients that requested our services more than once, and these were falls and lift assist. I've had our community paramedic Hillary Kosmicki follow up with the facilities to see what can be done. So I think we've got some positive results with that, with the current month that I'll be submitting. So, and I think that's no injuries were reported. And so I think, yeah, keep going, scrolling down. Yeah, this is just something Kyle put in there, that 32 males, 54 females. It doesn't add up to the amount of calls, but that's because some of them were repeats. So I didn't want to count each one of those. That's the difference in the total number. So, one of the patients had multiple fractures in their hands from trying to place their hands out. Another had a large hematoma on her head with no other injuries. The remaining had no further injuries from the fall. It was more, they were worried, wanted to be evaluated regardless. So, and so with their family members too. So, And Bonaventure, which is one that we're having a hard time with documenting any kind of use of the lifting device. They have two, one in their memory care, one in their regular assisted, and I have yet to receive any documentation from them. I've followed up with them. Hillary has followed up with them. So it's just a matter. I'm hoping they get kind of tired of us pestering them and they start filling it out. So we shall see. And then I think let's keep going down. And so, yeah, I think I put in here, we started seeing a downward trend. We've offered multiple times now for training for the new employees that have started since we've implemented the program. And again, the biggest challenge is getting them to use the tracking sheets that we've given them, and they've got one for every month. So it isn't something that they have to keep repeating. We've got a booklet that Hillary had made, and so they have one for every month. So there's really no excuse, for not having the correct forms. So it just, I'm not sure what the obstacles are, other than that it's out of sight, out of mind. And so we're still working on them with that. And then with 27 uses of the lifting devices, so I count it as a huge win, because that's 27 times that we didn't have to go to the care facilities to do a lift assist. And I do think that they're getting better on their evaluations also. That was something that when we implemented that, we had retrained them on the evaluations and so forth. So Quell Run, and again, you'll see it this for the month of March. There are super users, and I have followed up with them multiple times. I appreciate that, and I'm hoping that the rest of them will catch on. So, yeah. Any questions? Okay, that's it for me.
Thank you, Ray.
Yeah.
And for what it's worth, I have been working with Hillary on those high utilizers, as we shouldn't
Okay.
have high utilizers in care facilities.
Yeah, it's unfortunate we do, but I did see a decrease in March, so that tells me that we're making some progress.
Good, thank you.
Yeah. Thank you for your help.
Tyler, Amy's not going to be here. Would you be able to present today?
Yeah, so I can talk through the numbers since I'm the numbers person, but I won't be able to necessarily answer any questions on what the program's been seeing out in the field. It's been much the same as we have been reporting. February is on the lower end. Taking a quick glance ahead at March, we're kind of seeing a trend at the lower end at this point in the year. However, these are some of the traditionally slowest months for the department, if we can call a month slow for the department. So it's not too shocking for where we're at right now. But we did see 16 incident responses with 14 identified patients. You can go ahead and just keep going through. I'm not sure I'll have a lot to add unless there's any questions about the numbers, since it's pretty established how we are reporting at this point.
Sid, as a general question, recognizing that I lack a background in this kind of work, I'm noticing that the transports to the hospital are running 50 to 70% of the instances. Does anyone have a feel for whether those percentages of transport versus non-transport are usual or common?
And
I
so
would-
do you mean in terms of overall EMS calls, or do you mean in terms of lift assist?
In terms of lift assist is what I was thinking.
I would say, I don't know, Nate, if you and Jimmy, if you want to jump in, that would be pretty high for lift assist to be transported. It's about 60% of the time. It should be much lower than that.
Yeah, and perhaps I've misread it. I'm looking further at Eugene Springfield, and there are many things other than lift assist on this list.
There are.
I have to remember to broaden my appreciation of these specific units.
Right. And Rob, please correct me if I'm wrong, but it's somewhere around the high 80th percentile on 911 calls that end up resulting in transport.
That actually is degraded. It's, more likely 70%, sometimes even 68%, depending upon the area and the response area, right? Some ASAs, the percentage is higher.
Yeah, I was trying.
Thanks.
Go ahead.
Go ahead.
I was just going to say for Albany.
I was saying thanks very much. Over to you.
I just thought for Albany, what we tend to see is it's mostly, they've convinced the patients to go for either CYA, or they've convinced their families to have them transported to make sure that there's no other issues. So that's really where it's at for us.
Yeah, thank you.
Hey, Bill, do you think you could chime in? Do you know that maybe off the top of your head where you guys are at? No.
And so I just pulled up the stats for Eugene Springfield Fire. Overall, this is all calls, not just the AR2 calls, the senior response calls. Our transport rate is 60%. However, a lot of those calls, medic is not dispatched on. We just have an engine respond or AR2 or the other alternate response unit. Based off of our data to really trying to send medics to calls where we believe a transport is likely. So for incidents where an ambulance does arrive on scene, our transport rate is about 76%.
Thank you, Tyler.
Again, thank you for that background info.
Yeah, of
Hey,
course.
Francis, I'll just add a little more context. This demographic that we're talking about, there's a lot of complexity and chronic disease processes in these individuals. And as in the field, the clinicians, they can really only assess and then give their recommendations. They can't clear somebody. So the transport rate should be higher in this demographic based on that.
Thank you.
Hey, Tyler, what is the associated AK?
So that's a part we're working on trying to kind of clean those up so that it falls more correctly into the other bins. These are addresses that are part of a licensed facility, but are not. So it's a complicated piece. Essentially, these are addresses that are coming in where the licensed facility, the license is under a different address, but we've identified that this address is actually associated with the licensed facility, but the CAD response is going to the other address. And so as a bulk, we aren't able to right now, just in the data reporting, directly connect those over to what the actual license type is, because there's a bunch of different ones of them, and we're working on trying to kind of clean that up right now.
Thank you.
Yeah.
Yeah. Yeah.
And we still, the patient demographics is going to be kind of a continuing challenge. I don't have a good way of pulling patient demographics for the specific group that that the senior response unit is responding to without pulling patient demographics for our entire call volume, which is something because of how the report is set up, I'm trying to avoid doing. So it's a piece that we're still kind of working on and balancing
So we coded somebody at
how
Bruce
we're
Lake.
using that data.
Hey, Rob, you're not muted.
Sorry, everybody.
And that's that for the report with the individual calls. If there's any questions.
Thank you, Tyler.
I have one follow-on, Tyler, and you probably can't answer it, but I'm going to ask you. I'm just kind of curious. Culturally, do you get a sense that the crews and the organization understand the program at this point and they're utilizing it? Or do you feel like there's still a lot of learning that needs to happen?
Ooh, that is a bit of a hard question for me to answer
Okay.
since I sit up in the
fine.
admin floor. The crews I have talked to seem to understand the program well, and have wanted to actively connect with it and understand how the program fits into the response system. I will say though, with the caveat, the crews I generally talk to are the ones that are coming into the building, are kind of actively participating in these types of programs. So there is more of a connection there. I would say from the other little piece I do kind of know with it is I think there's generally kind of a more of the challenge of not necessarily not understanding the program, but wanting the program to be able to do more than what we necessarily can. So I know one of the common pieces is, why do they only go to licensed care facilities? Why can't we send them to other incidents that are senior EMS care related, but outside of the licensed care facilities? That's been the common point that I do here.
Thank you.
Of course. And I'll relay that question on to Amy as well, if she has anything to add.
Thank you, sir. Any other questions for Tyler? Okay, hearing none. Nate, are you able to present your report?
Yeah. So last month, again, we kind of continued our focus on the CPR and AED training in the facilities with both staff and the residents who wanted the training, wanted kind of the information. We also have our new extinguisher prop that we've been able to get out and start utilizing within the facilities. So that's been a lot of fun. It's a lot easier to set up. We can get a lot more people through it than the older style of just the sheet pan and everything. So that's been kind of nice. And then the majority of this month has been focusing on Green Ridge Estates had a near fire. It was a washing machine in their second floor laundry room that actually malfunctioned and smoked up the that whole room and then a portion of the second floor. So we responded there, and then I felt afterwards that wanted to do kind of a report on that one, kind of the lessons that they learned from that and the lessons that we learned kind of from their response and how to kind of inform us on how to better present some training in the future. So some of the things, and I'll let you scroll down to the Green Ridge. Should be just a couple more paragraphs. So a couple of things that we learned in the fire, there was 67 residents and 15 employees. The employees were able to get all the residents evacuated within the first 5 minutes of acknowledging the alarm. When the first arriving engine showed up, engine 210, the last remaining resident was evacuated prior to them even making their initial entry. As they walked through the facility to locate the source of the hazard, they noticed X's that the staff had marked on every single door that they had evacuated. So just an example of how training and being in these facilities and working with them really did, in a real world situation, kind of come to fruition, and everybody was safe, everybody was evacuated. And then there was a few things that we kind of were able to learn. If you scroll down a little bit more, I have kind of a brief after action there. Some of the things, like I said, that went well. They were quick to identify the hazard. They were efficient in getting everybody out. Some of the little things, though, is once all the residents were evacuated, they have identified 2 different evacuation points, but they weren't actually utilized during the evacuation. I think it was everybody get them outside, and then it was a little bit of herding cats after that point. And so we kind of identified, like making sure that everybody gets to that point of evacuation, and then also going back to the ICS training that we're kind of implementing into the facilities, is having somebody who will come and talk to crews or the battalion chief. That's the one thing that the battalion chief identified, was nobody was there to actually give him any sort of handoff report. So everything, for the most part, went really well, but there's a lot that we can kind of take from that and kind of inform future trainings. Kind of the cool thing with this program is we're constantly changing and adapting based on the needs that we see as we're out in the field. So that was kind of mostly what we worked on this month, was doing the after action with their staff. That was the first one that they have done. So it was kind of interesting to get their feedback, see how they felt about everything, and then kind of listen to them and hear what they thought that they could have done better on. In the end of this, kind of as one of the attachments, I did put the after action that we worked through. And then the rest of kind of that month and then this month is just prepping for the May 7th evacuation drill at the Stafford. It's going to be a pretty large drill. We're going to use fire, police. We're going to operate within our EOC. So we've been doing a lot of like plannings, meetings, and kind of tabletops, just getting ready for that drill. So that's kind of what the report is. And then down in kind of the attachments, I have kind of the after action, the stuff that we learned from the Green Ridge fire. Crews were really happy when the crews showed up. They thought it was really cool that they could just go to work instead of have to start thinking about evacuation. And then again, having the X's marked on every single door, they thought staff did an amazing job with that, because it just helped them identify which rooms had already been searched and already been evacuated. Obviously, we still do our primary and secondary, but it made our jobs a lot faster, a lot safer. It was less time inside of the hazard. So all in all, we counted it as a pretty good win, with some things that could be cleaned up for the future. And then sticking with our patterns, we're still seeing kind of roughly around 1 to 2 calls for lift assists from the facilities, the licensed areas, the facilities. So we're still doing quite a bit of outreach, working on with staff turnover and stuff, best practices. We have the Samson straps that we've been able to deliver to a lot of the facilities and kind of train them with that. So still seeing good numbers there. And then we are working on kind of similar what Tualatin Valley did, doing some utilization reports within the facilities as well. So hopefully we'll have those out in the next couple months.
Nate, this part of the report is what you just covered, right?
Yes, sir.
Okay.
And then this is the evacuation. This is what I was talking about. The red triangle is where the fire hazard was located. The outer blue X is the furthest ones away from the building. There was a couple people there. The majority of the residents were at the 2 blue X's next to the building. Again, we talked in the after action about why we need to get the residents away from the building. At that kind of upper left parking lot, it's hard to see in this, but the left side of the screen, the X closest to the building, was where the standpipe was. We were trying to connect to the FTC, and we had to our driver had to kind of weave through some of the residents. There was one resident who had a fall. after she was out of the building. And again, that goes back in the after action. We mentioned, having staff stay with the residents once they've been evacuated. So they did really well at getting everybody out. Now it's just little cleanup things. So I'm not a map guy, but this is as good as I was able to put together to at least give you an idea of where the fire was located, and then kind of where the staff got everybody evacuated to, and then in the future what we'd like to see. This is just kind of an example of our after action, what we do when we go in after every large incident stuff, what we do here as a department. I gave this to the director at Green Ridge, and we kind of adjusted a little bit to kind of fit more of their needs, but just kind of as an idea. That last one was the report of what happened. This is kind of the after action stuff that they identified, stuff we identified, kind of everything that we've already talked about a little bit. That kind of wraps up this last month's worth of work. And then, like I said, we're focusing on this next month on that May 7th drill, because it'll be a large kind of incorporating a lot of different agencies. So it'll be a lot of fun, but be good opportunity to kind of see. Green Ridge was good to see how it worked in real time. This will be good to see how it works kind of in that like pseudo real time, where we're not just doing a planned evacuation, but it's a planned evacuation, but then there's going to be a lot more players involved. So and yeah, this is just the chart indicating our continued trend of seeing our lift sys down to kind of the ones and twos.
Hey Nate, on the
Yes.
Green Ridge incident, I missed it. What was the time of day? 15 staff seems like
It was pretty quick. It was 12, what was it? 12:30 roughly.
Okay.
So they had 15 staff members. Like I said, they were fully staffed. So that the time of day did help in how quickly they were able to evacuate all their residents. Everybody was already up, moving around, had lunch and everything. Plenty of staff on the premise. So it would be interesting, and that's kind of why we did the after action, so they could kind of see how it worked really well with what they did. But now if they had left staff, how would they still be able to affect as timely of an evacuation?
Thank you. Any questions for Nate?
Yeah, Nate, Richard here. I had a couple questions, probably simple ones. For the X that you guys use on the door, was that something that's easily removable? And I'm just thinking about from the standpoint of cleanup for the incident that you guys had.
Yep, we went through with the facilities maintenance group and kind of trained on a few different things. We tried some grease pens, we tried a few other things. What we ended up landing on was just sidewalk chalk, just those large chunks of sidewalk chalk. Those we went with white. It shows up best on all the doors. Ideally, like a chartreuse or pink color would, excuse me, would have been better. White we found showed up well against flashlights and stuff. So just large white sidewalk chalk is what they're carrying now in their evacuation kits, keeping them on all the extinguishers and at the nurses' desks. And that way they can use those as they're ushering people out.
And do your crews carry anything like that for similar to use as well?
Yeah, we have like grease pens and stuff if we're doing like primary and secondary. We don't utilize them as often, but we knew in doing the training with the group that the staff at the facilities were going to mark doors with X's, so we knew exactly what they meant when we walked into the rooms.
Awesome. And then for your MCI drill coming up, is that going to be at another care facility? I missed that.
Yes, sir. That'll be at the Stafford. So we're going to do, it's going to be more of like a wildland drill, wildland that's approaching the Stafford. And so we're going to work on evacuating the license area of the Stafford. So it'll be a different facility. We're trying to spread it out a little bit.
Nope, sounds good. Thank you. Great. Great after action.
Thanks, sir.
Any other questions for Nate? Okay, thanks, Nate. You're off the hook, and just want to give you kudos. Your reports keep getting better and better, so thank you.
Thank you. Eventually, they'll be all right.
They're good. They're really good. Thank you.
Thanks.
Melanie, would you like to present your report?
Yep, I can do it. So for February, to get to that page 2, we had another month of no formal outreach documented by our community paramedics on the ARM unit. And I think in March it's going to end up being the same thing. So we've got a little bit of drift internally that I'll have to be addressing with them. But I make a little footnote. I would count every successful visit also as outreach because there is an education piece that occurs with the staff, family, and the facility in general. It's just we've kind of fallen off the slope of proactively just kind of popping in to care facilities and educating them about the ARM unit. I did make note of another interaction that we had that was kind of challenging for the ARM unit. This one happened down in Newburgh, where one of our medic crews had identified a patient who was experiencing nausea and vomiting the previous night. The facility activated 911 services the following day when I would say that the patient or resident was actually pretty stable. Essentially didn't need to go to the hospital. Patient and their family member was agreeable to being seen by the ARM unit, but when we informed the facility of our plan, the facility gave us pushback to the point that the medic unit basically didn't want to fight with the facility anymore and then canceled the ARM unit's response. The follow-up action ended up happening in March, but I wanted to throw it in there. So I reached out to the care facility and we sat down with the, it's a prestige facility. So it ended up being like their VP of clinical services and a couple of their nurses. And so we sat down and had a really productive conversation about the scope of the program. And through that conversation, identified that some of their concerns were actually based off of treatment that was provided by PMG at home, their like home services. So there was a little bit of confusion between our program and Providence's. But I think by the end of the conversation, we were kind of all on the same playing field and had the same understanding. So in the future, I don't think we're going to have the same pushback if we try to use the ARM unit again at that facility. So we were happy to sit down and kind of figure out where the concerns were. When we get down into our consults, we documented 14 phone consults that resulted in 6 accepted individuals. 3 were declined and 5 were not answered by the crews. So that would have been an initiated consult from the ARM unit where they kind of reach out to our crews and were either not requested or didn't receive a response. They also had 8 self-initiated responses. So our numbers actually went down a little bit, I would say, in self-dispatch. I don't know if it's maybe just not getting documented as consistently because we have had a little bit of a shakeup with who is consistently now working the ARM unit, just with where our community paramedic program is at. So something to work through with that group internally. For the month of February, we ended up getting 12 successful visits. 11 of those individuals were able to be discharged on scene. 1 had to be escalated and transported to the hospital. For the visits, it was 12 unique patients. 1 of them was a repeat patient. We had seen them in January, and it was for a different complaint. So that was nice to see. At least it wasn't a recurring issue for them. Just next section is the specific facilities that we saw and responded to in the month of February and how many patients we had there.
Yeah.
Because we're at a place where we're seeing a lot of the same care facilities. So I kind of need to just look at maybe some education with some of our other crews to expand our touch. Had a good 50-50 split, male versus female for February. Treatment details, 41.7 received one or more diagnostic tests. 33% of patients were treated with one or more procedure. I did talk to Dispatch Health about why that didn't equal 12, as I would have expected, or exceeded 12. And it sounds like there could have been some of our patients that were just received an evaluation and were cleared to stay at the facility, so they didn't necessarily require treatment or diagnostic testing. For the month of February, we had insurance coverage was about 50% Medicaid, and then 25 for Medicare and then Medicare Advantage. And then something that I approached a little bit differently for the month of February, and I think I'll start doing for the remainder of the year, is how I did our estimated cost savings. So previously, I was just basically taking our agreed upon 2024 average cost of the ED visit, and then AMR's Washington County base charge for BLS transport. Just, adding those two together, timesing it by how many patients stayed. But after a conversation with our medical director and some other changes that we've seen in our ALS versus BLS transports and units in Washington County, I'm now kind of averaging the cost between, so I use the average ED cost, and then I add it with a BLS and an ALS. So I basically make two different numbers, and I'm averaging between a AMR, ALS, and BLS transport base rate, and using that as an average to try to split the difference. Is realizing that it might not actually take that much to take some of these transports from a BLS to an ALS billing rate. I think we were undercutting our numbers a little bit. So for the month of February, our estimated cost savings came out to about just over 40,000. And so I kind of show my work here in the footnotes, how I came up with that number. And then we had 11 surveys collected for the month of February from the people we had visits with. And again, just continuing to see really high satisfaction responses. So everybody this month was all high marks. Weren't really any comments that were being provided. But that's kind of the trend we're seeing, is the residents that are being seen by the ARM unit are generally really satisfied with the service, at least per the survey.
Rob?
Yeah.
Hi, maybe this is an offline, Melanie, but how connected is the ARM unit to the nurse navigation platform in Washington County?
They're not connected.
Okay, that'd probably be something offline, Jimmy, maybe we talk about, because it sure seems like they marry up nicely to each other.
I would agree that one of the challenges is that they have a pretty constraining time, so they're only on Wednesday, Thursday, Friday from 7 to 7.
Yeah.
So, but yeah, I'd love to talk further. Yes.
Okay.
Yeah, we have talked about that as a division with our Dr. Daya. I know is really would love to tie in the ARM unit or even Dispatch Health into Nurse Nav. It's just kind of, I think that conversation's gotten a little bit lost, and then also the restraints of staffing.
Yeah.
So,
okay. Well, we're available whenever you guys want to jump into that and try and get those two platforms connected, because I think they'd complement each other.
Yep. Just not to take too much time. Part of the challenge, Rob, is that it's, the grant is specific to licensed care facilities. As you know, at the PSAP, they don't have the ability to understand what is a licensed care facility. So then it gets muddy really fast as far as even getting them over to Nurse Nav, and then we'll allow them to get to the ARM. So, but yeah, we'll talk further.
Cool. Thanks.
Hey, Rob or Chief Samario, we have a few people on the call that are probably not aware of what nurse navigation is. Could we please get maybe a 2-minute, 10,000 foot level view of that?
Sure. I think Jimmy's conceding to me. Yeah, Nurse Nav is essentially a version of telehealth that interjects and becomes involved in 911 systems. It's a global medical response platform provided by our parent company, where nurses are available 24/7 to intake lower acuity call types in hopes of navigating them to primary care physician, urgent cares, They assist and support with pharmacy and getting pharmacy delivered, lift rides, et cetera, to try and excise those particular call set types out of the 911 system to keep fire's heavy assets in their buildings ready to respond to the higher acuity call, and certainly ambulance availability in each of these systems. It currently covers Washington County. It covers Clackamas County. We have a presence in Clark County, Washington, just across the river as well. But we have around 60 sites across the country, with larger ones being in Seattle, Knox, Georgia. I think there's a large one developing out of Southern California. Our home offices for both of those are located in Texas and in Arizona. So they're large PSAP type comm centers. The one in Texas is actually housed with our Office of Emergency Management, which is our FEMA dispatch center for all of our hurricanes, natural disasters, et cetera. So it's a pretty amazing thing. It's doing wonders for communities who are trying to strike call types and getting the right resource to the right person.
Thank you. Any questions for Melanie? Thank you, Melanie.
I could interject for the folks, around the state. We have become involved in the rural transformation fundings coming from the Big Beautiful Bill. We've made appeals to all 50 states to consider NurseNav, particularly in their rural areas, in hopes of trying to help where some of these EMS deserts are starting to develop.
Thank you. That's actually very helpful. Okay, Chief, back to you.
All right, thank you everybody for your reports. I would echo that they seem to be getting clearer and easier to read and understand, and they're all operational, so it's super exciting to see. I appreciate the work by everybody. Next item on new business is discussion on minutes and website. Probably gonna go right back to you, Sid, maybe for an explanation of that stuff.
Okay, so Nancy and I might jump in and out here. What happened with the website hosting is, in order to have the accessibility requirements met through ODHS, they have asked for a couple of things, but the big takeaway is that in order to have our agenda posted on the website and our minutes posted on the website, they need to be branded, and they can either be branded with a particular logo from the EMS Council, or they can be branded with an ODHS logo. So we did attach what that would look like with the templates that they have provided, they being the SharePoint team where our website is hosted. A lot of the advisory councils to ODHS use those exact templates, and the argument there being that you are, in essence, volunteers to ODHS. So I could understand not wanting to be branded as part of ODHS, but really it's just a template signifying that we've done work. So if we're going to continue to present written minutes, then we would have to switch to something that is branded. That said, before we continue discussion, I went ahead and looked up the law just real quick, and I have it highlighted here what the ORS is. And since we do not meet in person, we meet virtually, we will have to continue to post the video. And if we continue to post the video, which we have to do no matter what, then we don't actually have to continue having written minutes. So that would be the takeaway here in terms of discussion is, do we want to either continue with written minutes? And then if so, would it be acceptable that they're branded in the new template that we shared? And then additionally, the agenda would need to be branded as well.
It's a lot to
Questions or
unpack there.
comments? Yeah.
So can we kind of break that into a couple pieces? So let's just talk about the meeting minutes.
Okay.
I guess I would ask, is there an administrative burden to do the meeting minutes?
Not particularly, no. It does take I mean, this is an hour meeting typically, sometimes a little bit longer, sometimes a little bit less, and it's usually about a 3-to-1 minute per minute in terms of getting the minutes done. So not an overburden, and we're here to support the council either way.
And for me, the logic is it's a lot easier for me to pull up the minutes and kind of peruse through them and read them versus if I was to pull up an hour video and find time in my day to listen to an hour video so I can reference it when we talk about, the meeting minutes view. Are we able to use AI for the meeting minutes?
That's what I was going to ask, Jamie. Yeah.
Yeah, we do. We do that through Teams here. Unfortunately, it is not accurate by any means.
Council, anybody else got any thoughts?
I tend
curious.
to agree.
Go ahead.
I tend to agree with the earlier comment that if the administrative burden is not excessive, the minutes provide a very good shortcut and might actually clarify some of the discussion when an outsider would go and read the minutes to understand what had happened. So my take on that would be that we should consider continuing to post the minutes and accept the branding requirement if so. I'm not always right, but never in doubt.
I said, Richard here. I don't know if we're bound to using Microsoft Teams. We use Google Meets as another platform, and it does a pretty good job taking minutes. So if there's an option, you could try that.
Yeah, we're not bound to anything particular as long as it's 100% publicly accessible, and that if there's any ADA requirements, we can meet them through that platform. And of course, we'd have to obtain a license. So we have a
Sure.
license for Teams and we have a license for Zoom.
All right. Sorry, that was just an idea. We use it as another platform. It does a good job taking notes, but as all the legalities go, I'm sorry I couldn't help you there.
What was that called again? Google Meet?
Yeah. Yep. As far as I know, it's a free platform, but I could be incorrect.
I will look into that. Carl?
Yeah, we use Google Meet for our company. We do have a paid service for it. If you want a meeting to last over an hour, you have to pay for it. If it's under an hour, it's free, but that's the really only hiccup that I find with it.
Thank you. I will look into that. Perhaps we already have a license for it.
Okay, so it feels like we've got a couple things to solve here. I'm not sure we're gonna. So do we feel like we're at a point where we want to have a motion and a decision on how the technology, whether we do video or we do meeting minutes? Because I think we have to have a separate motions here for me, for my head, to break this all up, because it gets there's layers, and that seems like the simplest layer to solve first, and then we build off of that.
So let me clarify real quick, if I may.
Okay.
The video that we're doing right now is going to be posted because it's a requirement if we continue to meet virtually. So I don't know that we need a vote there. What the vote would be, the motion would be, is do we want to have, in lieu of written minutes, only the video recording?
Okay.
Or to rephrase that, Sid, to look at it the other way and to say the motion could be to agree to continue posting the minutes or not.
Correct.
This is David. I would like to make a motion to continue posting the minutes, because searching minutes is just, for anybody that wants any information, infinitely easier than watching a whole video. I mean, it's like looking at a text versus listening to a voicemail. You can get right to the information you need. There's no really, without advanced AI, there's no way to pull information out of a video like that.
I would second the motion to continue posting minutes, recognizing they need to be branded.
Okay, I got a motion and a second. Any further discussion on the motion?
Nancy, do you want to chime in here?
I
Are
don't
we
have
covering
anything
all
to
the
add.
topics that we needed to?
If memory serves, yes, just a matter of replacing the written minutes with video and approving the branding as submitted for the written minutes.
Okay, thank you. And that meets all of our accessibility concerns that they had as well, right?
That is correct.
Okay, thank you.
Okay, any discussion to that? I think I'll just add kind of some of my thoughts here. I know she thought it was an either or, not a both. So the both doesn't really change anything for our standpoint. It just now puts the video out and it makes that meet probably the ADA compliance and some of those other things that we needed to meet. We can still have our minutes. So if somebody needs to peruse them, look for thing, get a quick update before we step into this meeting monthly. And then the branding, based on the stuff that you sent out, all looks good to me. So if we're in a good spot, should we take a vote? Okay, we'll take a vote. Roll call. Start with on my screen here. Chief Vetch, yay or nay?
Yay.
Francis, yay or nay?
Yay.
Rob, yay or nay?
Yay.
Carl, yay or nay?
Okay.
Dr. Lauerfeld, yay or nay?
Yay.
And Denise, I don't see you, but I think you're in the meeting here. Yay or nay?
Yay.
All right, and I'm a yay. Unanimous vote. Thank you, everybody.
Okay, thank you.
And I apologize if it creates any additional work for you, Denise, or it doesn't make work go away for you. But kind of where we're at. All right, it looks like we have next item on the agenda is, I'm sorry, my screen's messing with me here. We have public comment. Is there any public comment? Going once, going twice. No public comment. We'll move to good of the order. Sid?
Okay, I do have something. As a requirement of the bill that we're operating under, it is incumbent upon the department to do checkups on the grants, as we've discussed before. I did that last in December, I think it was. This time I will be doing it in May. So I'll be reaching out to all the grantees, and it needs to be a little more extensive than the last time. I know Melanie and we've chatted about this. I'll need to do things like ride-alongs and site visits and that kind of thing. So just want to let you know I'll be trying to schedule that for next month. And that's all I have for updates. Thank you.
Okay. Anybody else have any good of the order? I have one question, Sid, that kind of parallels the work that this council does. I noticed last week we got a provider alert sent out through HS. Is that, can you tell us or the council here how those come about and how those get messaged? Kind of the,
Sure.
I'm a bit ignorant to it.
Sure. So the provider alert that Chief Samario is referencing is in terms of non-emergent calls coming in from licensed care facilities, being assisted livings and residential care facilities, where someone needs to be seen, say at their regular doctor, and facilities are calling 911 to make that happen. The provider alert is a reminder to those care facilities that that is in violation of the Oregon administrative rule that they've agreed to adhere to based on their license. The way that those come about is, in this case, when a fire department and ambulance service says, hey, we're having this particular concern, we vet the concern. We find that there is more than it's more universal than just that one agency that we can tackle, from one care facility, that we find that's a universal thing that's happened in other places. Then the folks that do the licensing, safety oversight and quality, I work with them in this case to say, here's the issues, here's where it fits within rule and statute, and then we release the provider alert. And it typically goes out to anyone that has signed up for the list, which again, the providers are already responsible for those rules. So it's a reminder to them, and anyone else can sign up if they just want to know, or sometimes interested parties that might have another avenue to ODHS, like fire departments and ambulances. It would be my responsibility then to communicate those things to them. Does that answer what you were looking for, Chief?
Absolutely. I have a couple quick follow-on questions. So that's the second one I've seen in my kind of tenure in my current role. So are those housed somewhere if we wanted to reference them? Past provider alerts.
They are. I believe Melanie has the website. She can get it to you. They are on a publicly facing website that anyone can access.
Okay,
and if you need
perfect.
that, please email me and I can get that to you.
Well, it wasn't, I was
Okay.
thinking more of the collective of the
I've
council.
got the
to know that
hyperlink
they
saved.
exist.
Yeah. Yeah.
Okay,
Google will take you right there. No, there's nothing hidden with them.
Yeah, perfect. That's all I had.
The reason why
Anybody?
there's only been two, Chief, is my position's only existed for a couple of years. I think we're on the 4th year now. And on that, as you know, it takes quite some time for state government to move on things like that. So, like I said, I have to get the information, vet the information, and then pass it through the right channels in order to get those things out. But we will get it done.
Thank you. That sounds familiar. I feel like I must work for a big government agency too, because that's how everything gets done here. All right. Any other good of the order? Thank you, Sid. Hearing none. Items for next meeting. Do we have nothing tabled, I don't believe. Well, I guess maybe we have something we're still trying to work through, Sid, and that's our governing document. Are we good with
No,
that?
you approved that.
Okay, I'm just confirming that we're good with that. Okay.
Yeah.
All right.
And,
well,
because my site visits won't occur until after the meeting, the report for that will not be at the next meeting.
okay. And then I guess moving to that, our next meeting is May 4th, 2026. I really appreciate the attendance today. It's refreshing to log into the meeting and not clutching my pearls, wondering if we're even able to have a meeting today because we have a quorum. So thank you everybody for attending. I really appreciate it. Allows us to get through it and acknowledge the great work being done by all the agencies out there under the grant. That said, meeting is adjourned. 10:30, we made it.
Thank you,
Appreciate
everyone.
everybody.
Thanks,
Thanks
guys.
very much.
Thanks.